Thank you, Dr. Gordon, for having me today. The one slide I don't have is on disclosure, so I just want to make sure up front that I'm not hired by Shockwave Canada. I did represent him in Berlin under Dr. Gordon's name, so he probably won't be invited back to Berlin anytime soon. But I've worked with Shockwave since 2006. Dr. McKelly and myself have had it in our clinic at the Toronto Athletic Club. My presentation today, I promise there'll be no bar graphs or anything. This is more applicable to the clinical practice, and we want to give you a clinical perspective of how to use Shockwave. So this is coming from experience from 2006 until today, and we have some of our therapists here today also. We have a multidisciplinary clinic, and so we have massage therapists, chiropractors, athletic therapists, physiotherapists, all working in the same clinical environment. And we've all been exposed to the radial shockwave, and we've had terrific success stories with the radial shockwave, and we hope to have even more success over the years to come. And I can honestly say the applications have grown over the last 10 years that we've been exposed to it. So this slide here, all it really shows is that either I'm really old or really experienced, I'm not sure. But I've certainly been in the sports medicine field for a long time, pretty much my whole career. And as with Dr. Gerdsmeyer, his presentation on sports medicine, I really believe Shockwave has an application in sports medicine. I think over the next 10 years, this modality is really going to be helpful in a lot of different areas of sports medicine and orthopedics. Again, back to the Toronto Athletic Club. We're located right downtown Toronto, right behind the Royal York Hotel. We have a lot of high-end Bay Street clients, as Dr. Gordon knows and can comment on. They demand sort of getting better yesterday. That's their philosophy in business. That's their philosophy in how we treat them. So Shockwave definitely fits into our sports medicine program at our clinic. That's what our initial interest was, and when we were exposed to it in 2006, my only thought for it was insertional tendinopathies. But with insertional tendinopathies, just Achilles tendon and shoulder alone, we could justify the use of radial shockwave. What we found in 2007 when we went to the conference, and it was here in Toronto, Dr. Gordon invited Dr. McKelly and myself to go. We listened to a gentleman, Dr. Gleitz, and he had a whole concept on myofascial syndromes and trigger points. So here we were thinking insertional tendinopathies, and now all of a sudden somebody's talking on a much broader spectrum, looking at the muscle bellies, looking at the tendons, and looking at the trigger points. And so we walked out of that conference, and we were really excited about the application of radial shockwave. So we actually purchased one of the units. It was a radial shockwave. It was the MP100 at the time.
Charge you double.
Yeah, stiff does. We started using it on much more areas other than just insertional tendinopathies. And I can honestly say today, some of the treatment profiles that we'll show you, our thought process is going more and more into a holistic approach using the radial shockwave. So some of the questions today, do you use it on Osgood-Schlatters? Do you use it on lateral epicondylitis, frozen shoulders? I think what we're trying to bring across here is a much more holistic approach where we're getting out of specific diagnosis and looking at it more from a treatment flow. And I think as we progress with this, you'll see what we're talking about. It definitely helps the clients, but I think what's going to come in the next 10 years for manual therapists is how to improve the longevity of a manual therapist. There's a lot of therapists out there that get hurt or that have injuries from working the years that we do. My philosophy myself is no brain, no pain. I've probably been in here long enough in the field because I just don't feel the pain. But there's a lot of people that do feel pain as manual therapists working within the field. And I think if we can find a modality that helps us to do our work without having to put such manual effort into it, that in itself should pay for the machine. So one of our best investments, I mean, we have 24 practitioners that work in our clinic. If our investment into radio shockwave is just to increase the longevity of our manual therapists, then that alone is almost worthwhile. And one of the talks in Berlin this year was talking about injuries to therapists and doctors using manual techniques. So radio shockwave has a fantastic ability to sort of lower your workloads. Effectiveness clinically. Dr. Gerdsmeyer did a wonderful job on showing sort of what the overall effects of shockwave are. Bringing it back to my perspective, tissue does not lie. And when we started using the shockwave in our clinic, there's absolutely no question we saw a decrease in pain and increase in function with all of our clients. We have a very athletic client base, but those two things alone, you know, the research sometimes will catch up to what we find, but patients love it. Patients want it, and when they get the results as quick as they do, you will continue to build a practice just on that alone. So tissue does not lie. Is my time up?
Yep.
Oh, geez. It's getting going. The first part was tissue does not lie. The second component, always think about the energy input into the tissues. And when I first started using shockwave, you know, we had the MP100. And if the 100 is good, the 200 must be even better. So I was just thinking energy. Like, the more energy we can put into that sucker, the better. And I love that slide today where you were showing the shockwave, you know, dissolving the bony mass. That's how I envisioned shockwave when I first started using it. More energy in that the patient can tolerate, the better it's going to be. And with our client base downtown, it's like, you know, you got it at 2 bars. If you hit me at 5 bars, will it get better quicker? And what we're finding over time is the component about how much energy goes in is not make it a more effective treatment. So when we talk about pain scale of 1 to 10, we need to scale it back a little bit. I think some of the therapists that are using the shockwave, they're like, whatever you can tolerate, that's what I'm going to give you. And that's not the indication right now. The indication worldwide seems to be much more along the lines of, we'll start you, you know, on a scale of 1 to 10, 3 out of 10 is what I want to feel. And as you start to desensitize the area, then you can up the energy that's going in. So 3 out of 10 is kind of the guideline that you want to use. If you have your client sort of grabbing onto the side of the table and holding on for dear life, just bring the energy down and then work your way back up. And some people have been, patient-wise, have been exposed to shockwave where they're saying it just hurts like hell. I think we have to back it off a little bit. Over the next period of time here, you're going to find more and more people using shockwave at lower levels of energy and building their way up. And I know with Dr. Gordon's clinic, what's 2.6 is kind of what Brianna has told us that you guys are your standard to build up to, you know. So starting at 1.8 and working your way up if you have to is a concept. We use the frequencies are mostly at our clinic. I use 11 hertz and 15 hertz. Some of our therapists use 13. It's a real science right in between. Shocks of about 5,000 per area. Now, 5,000 sounds like a lot, but when you see sort of some of the protocols that I use, 5,000 will start to make sense to you. And we do use the MP series, the radio. Anything to add to that so far, or?
Thank you, it's good.
So again, when we talked of our initial exposure to it, it was insertional tendinopathies. So insertional tendinopathies or enthesiopathies, traction pull on the tendon insertions. You know, if you think of the Achilles tendon, for instance, it's that pull right on the Achilles tendon, right close to the insertion point on the calcaneus. Just 3 components to think of. We'll go through some of the practical. I want to spend a lot more time on practical than I do on slides. So we'll do some of the practical components to it. The pressure on the handpiece, it's really about comfort. And what you'll start to feel is when you start really using radial shockwave, the handpiece really just becomes an extension of you. So your pressure is really just an extension of you. So you don't have to dig it right in there right off the bat. You can work your way in. I think massage therapists are very accustomed to sort of working their way into the tissues. Same thing with the handpiece. You don't have to put a lot of pressure through it right away. And then when we first started, we just had one headpiece. And the head size itself was just a standard one. Now, I mean, we've got a full case, you've got a full plethora of headpieces that are available. They all have their specializations, and it's an exciting time for radio shockwave because we can apply radio shockwave so many different ways now based on the head size. So we use a C15, which is the regular, and then there's a deep impact head that we use for these. Some of our athletes are very big, like football players, hockey players. So the deep head impact works really well for us. And then just a concept on these, if you look at the number of shocks, you can equal up to 5,000 on the left-hand column. But really what we're trying to do initially on these is a lot of therapists and physicians, they would just go directly to the Achilles tendon. The individual points to the Achilles tendon and say, this is where it hurts, and that's where they went to right away. And sometimes it's a real sensitive area. And what we found is by going into the trigger points, tracking down some of those trigger points in the muscle belly first, and doing the shockwave on those muscle bellies takes some of the tension off that tendon right away. And then going in, and we talk of trigger points, I mean a true trigger point should create a referral pain. So sometimes you'll hit these points and the client will say, I feel that elsewhere, or that refers. That's great, that's a trigger point. But there are some fascial restrictions in areas where it's just tender, there's no referral pain. And one of the areas we really find in a lot of the musculoskeletal conditions is the MT junction, or the musculoskeletal junction. So if you think of it in the Achilles tendon, right where the calf and the Achilles tendon come together, it's a really restricted area. And you can get in there with a shock wave and kind of just loosen up the stiffness that's in that area, free that up, and then go right down to where they actually point to the pain. So you kind of, it's a little bit of a setup before you get right to the focal point or the epicenter. So this is what we do for our insertional tendinopathies. That's one of the protocols. And I'm going to have Brianna come up and show that. Brianna, maybe while I'm talking on the other two, if you can just grab a chair and we'll bring it right in the front and I'll introduce. The next one is the myofascial syndromes. And that's really a lot of the work that Dr. Gleitz did. I have these books up here after if you'd like. This was the one that was initially, just came out over in Berlin. So this is the most up-to-date on multidisciplinary medical applications. So it has a lot of the indications for shockwave in the book. And the insertional ones, a lot of the work comes out of this book. Seems to be a lot of Germans in these books too. You guys are really smart. And then Dr. Gleitz's book that, again, back in 2007 when we first met him, a couple of years later he came out with the book. And I've been using them all as references. But the myofascial syndromes, the real difference here being it can be in a local or a large area of treatment. So this could be something along the lines of quadricep, IT band. We can look at calf muscle. So a lot of different areas, especially in sports medicine. Again, we talked pressure on the handpiece already, and we'll do it in the practicum. If you take a look at it, we still go right into the muscle belly. We take out whatever trigger points are in the muscle belly right away. Then we look at the painful muscle spots of the muscle belly and tendons. And then the important part at the end here is a smoothing applied at a low treatment pressure. It's a great way to end off the treatment. Now they've come out with a deactor that can do it also. Our clinic doesn't have one yet. Dr. Gordon keeps reminding us of it on a weekly basis. We're certainly shopping it. But it's really important that the client leaves with a sense that there's something, of therapeutic value, but also of relief. And I think a lot of therapists forget about doing that smoothing at the end. which is at a lower intensity, higher frequency a lot of times, and just kind of smooth out the area so that there's a pain relief factor as they leave. So we're going to do that in the practicum too. And then the last one is treatment of fascial pathways. And I think this is an area that I'm delving into a lot because I get clients, we talk of 3 to 5 sessions of Shockwave, but I get clients that are triathletes, marathon runners, hockey players, tennis players that come in just for what I would term fascial pathway treatment or tissue regeneration, where their IT band's chronically tight from marathon running. They just want to come in and get their IT band freed up. So part of what we do is regenerate and reorientate the fascial pathways. And I think this is one of the really key future areas of Shockwave over the next 10 years, that you're going to have a client base coming in just for Shockwave from a regenerative standpoint versus I have an Achilles tendon that's broken, fix it. We're going to be able to prevent a lot more injuries through the use of Shockwave. Based upon for us, in our clinic, we use the fascial distortion model. It's a model that was devised in osteopathy. In January, our clinic's holding another course that if anyone's interested in following it up, they could certainly contact us and we'll let you know what the dates are and the costs and everything. There's a few therapists in the room already that have taken the fascial distortion model. In sort of quick summary, the fascial distortion model basically looks at fascia in 6 different ways that it can distort in the body. And the 2 big ways for us that Shockwave seems to help is with the herniated trigger points and the primary trigger bands. And trigger bands are kind of like just these long fascial bands. If you think of the IT band, it's part of a lateral trigger band. So when we look at these fascial pathways, first thing we do is the herniated trigger point, we'll take care of that. Then we go in and we take a primary trigger point and work on that with the Shockwave. And at the end, we, again, smooth it out, kind of free things through. When we do the practical, we'll cover that. I just want to talk about post-treatment recommendations. And then again, in the practical part, we'll do just Q&A, whatever you want to ask. These are some things that are really important, I find, from a post-treatment recommendation. Most people after Shockwave, the first question you'll get is, can I be active? And the answer is absolutely yes. Do you go back to, full on activity? Well, if there was pain before treatment, probably not after. But you want to keep them active because part of what you're really trying to achieve is you've taken care of tissue restriction. You want to maintain that tissue memory now. You don't want to lose that memory. So, people will be sore potentially after the treatment. Don't tell them not to be active though. If there's soreness, that's to be expected. And what you want to be able to do is tell them to stay active with it if they can. The other part with it is immediate reaction after, if they see redness or if they feel soreness or it just feels like it's being worked upon. A lot of patients, their immediate reaction is, I'm going to ice it. And we don't want to ice it. If anything, we want to heat the area because we want to maintain that good blood flow coming into the area, good quality tissue healing to be happening. MFR and stretching. The MFR is just sort of some myofascial release techniques. Again, a lot of the people you'll see have had chronically tight, stiff tissues there for a long period of time. You release it, and then if they don't do anything for it, it has an ability to tighten back up or shorten back up again. We want to maintain what we've gained. So increasing that tissue mobility, allow them, just emphasize it over time, especially the first couple of days. And symptoms should improve within 1 to 4 treatments. From a Shockwave standpoint, keep using the same modality with no change doesn't make sense. So when patients, I think it's important for patients to understand at the end of a treatment, and they say, how many treatments is this going to take? I think it's important that you say, you should notice change within 1 to 4 treatments. If you don't, we need to reassess or reevaluate. And I think that should be for any modality that's used. This is something I put in evidence-based practice because from my experience with working with Shockwave Canada and Dr. Gordon, this is his passion. His passion is to take evidence-based practice and integrate it with the best research evidence, as we can see by Dr. Gerdsmeyer here today, with clinical expertise, and that's what the therapist's responsibility is, to provide clinical expertise, and client values. And with those three components, you get great clinical outcomes. There's absolutely no reason why you shouldn't have great clinical outcomes. What's important is that we take the research that we have and we apply it to our practice in the best way we can. The take-home message from the talk today for me was that 40% placebo effect, take that back into your clinical practice too. I think the way you talk to your patients, the way you handle the setup and the treatment, you know, if the 40% placebo alone, your clients are going to notice improvement. So it's important how we talk to our patients and work with them. And the last component, our current use at the Toronto Athletic Club, we're going to go through the practical part with the enthesiopathies, myofascial syndromes, and fascial pathways. But in future for us, some of the things that I've started to really look at is the use of the radial shockwave on the epiphyseal plates, and as one of the heads that's up here now with the acupuncture, they're starting to use it in Europe a lot more, where you're actually doing shockwave on acupuncture points with the head that's specific to acupuncture. So there's some really exciting future for the radial shockwave. In terms of our multidisciplinary clinic, just gives you a perspective of how we charge it out on a regular treatment visit, anywhere from $135 to $200, depending on how long they're being treated for. Our clients expect rapid pain relief and improved functional movement. Those are sort of the two parameters that we look at every client from a success standpoint. And symptoms, as I had said, should improve within 1 to 4 treatments or reassess and discontinue.